with your own ears. Okay, he developed turbulent flow. Now, so I have to know what I'm listening to, and I don't give him pathology as I understand the physiology. Okay, so how I listen to him and what I tell him to do is important. Okay, so first of all, I watched him, and as I am still focused on the back, the easiest and best way to pick up restrictive lung disease, okay, at 5 in the afternoon when you're doing a consult and the guy's going to surgery in the morning, is with these two hands right here. You see my thumbs? You want your thumbs to be placed along the spine. He can feel me at about T8, T9 here. And then you spread your hands laterally over the chest, and I would ask you to drop your hands by your side so that he's not pushing up. And now take a slow, deep breath in. And let it out. Now take it in rapidly. And let it out. Okay, my hands told me two things. Number one, you're aware that between every rib, between two ribs, there are 3 sets of muscles. Here are 2 ribs. There's a set that run this way and a set that crisscross this way. And then there's a set that go up and down. Well, the ones that run this way pull these ribs up and out. Okay, and on forced expiration, the ones that run the other way push down and in. And the ones in between are the ladder with which he elevates his upper chest. Take a deep breath in. You see, he comes up at least a centimeter here. Okay, so his chest is up and out. Okay, and so when I look at him and I'm checking for restrictive disease, you have a physiology, a curve of how the chest expands and the airways open and elongate. Okay, they open and they uncoil or elongate at the same time the muscles pull up and out, so that my hand should be just as his did. If I'm examining my patient and he has no significant restrictive disease, now you can pick up pleural effusions this way, consolidated lung this way, pleural peals, an old tuberculous chest that's bound down, and so on. And let me give you an example of a unilateral restriction. Okay, here's Dr. Siegel. If he had a unilateral restriction, he'd had old tuberculosis, or he had plombage in this chest. Here's the way it would go. Okay, we'd go. See that? You know, it doesn't take physiology major to know that there's something that is restricting this chest. Now, with generalized restrictive lung disease, let's say advanced sarcoidosis or UIP, DIP, desquamated interstitial pneumonitis. Let's say you had this. You get what we call the doorstop effect. Okay, I say take a quick breath in, and he goes. Did you see how my hands do not move up and out any longer? Okay, they do not go up and out. They go up and stop. You know the doors that have a little place, if you open them and you let them go, they close this way. You know what I'm talking about? The little doorstop? That doorstop sign is a sign of restrictive lung disease. In other words, you open the airways, but when it reaches the hysteresis curve of the lung that is bound down, that has got interstitial fibrosis, it suddenly stops. But you have a nice curve of how you open your airways and expand your lungs. It looks just like this. Goes up and back, like this. Not square root, like this. Okay. So, I'm going to determine from his breath sounds several things. The quality of them for his habitus. Okay? He's got a normal chest thickness. Okay? A little myokyphosis back here, but his chest, his lungs are close enough to me that I can tell that he should have good quality breath sounds. Now, I'm saying to myself, are they normal for his habitus, or are they increased or decreased? First thing. Okay. The patient with emphysematous lung disease has a vacuous sound. You can hear a little inspiration, and on expiration, because it's long and slow, you just hear a faint expiration. Patient with interstitial lung disease who's got harsh crackles and has got areas of really consolidated, scarred lung will have these harsh breath sounds that are bronchial breath sounds. And so I'm saying, are they normal, decreased, or increased? That's my first thing. Then, do I hear adventitial sounds? Sounds coming from the lung parenchyma. The most important for you as a general internist are moist rales. So you're trying to determine, are the breath sounds normal, increased, and harsh, or decreased and vacuous? And are there adventitial sounds that occur? So, from the back, I began, and with the diaphragm, just breathe normally. No, that's fine. That's fine. I'm going to describe, okay? Okay, now, I said breathe normally, and he did what we all do. He didn't hyperventilate, but he took a little increased depth, and I heard he had opening sounds at the right base that disappeared with continued respiration. I don't know if you've ever had any process here. Okay. He says he is not. Okay. I believe him. And opening sounds are not when you wake a patient up in the morning and you're there at 6:30 and they sit up first time on the side of the bed and you put your stethoscope on their chest. They may have a few opening sounds because of basal atelectasis from being in bed, and they take a big breath, and if it does not continue, then it's not pathologic. He has normal quality breath sounds. So I've said to myself, for his habitus, he had these opening sounds that disappeared. It did not produce cough, okay? And I'm going to have him verify that by now taking as deep a breath as you can. Blow it out. Deep breath. Blow it out. Okay. I've done two other things. Can he augment his breath sounds? The answer is yes. Did he develop adventitial sounds with it or cough? No. Now, what adventitial sounds? The rales or rales that I talked about are sibilant sounds, wheezing or musical rhonchi, either one. And did it make him cough? Okay, now bedside clue about cough, it's always pathologic. In the normal person with normal airways, to the fourth generation, you can raise within 3 good expulsive cough any button of sputum that's in your airways. To the patient who has from moderate to severe airways, 5 to 8 efforts usually to raise sputum. It's an easy bedside test. You're usually looking. I had all my patients who had any adventitial sounds try to produce phlegm because I would take it, do a wet prep, look for EOs, and then do a little stain and check it. Now, I have checked him for restrictive disease. I have listened with my ear for normal, increased, or decreased. I've seen can he augment, and I've seen does it produce cough, or does he have adventitial sounds? Okay, those are all critical. Okay, now, and I've looked and assessed his chest wall. I've got his spine, and I now do one more thing, and that is at the bases of his lungs, with some pressure with my hands, I have him take one more deep, slow breath, fully in, all the way in. And I verify very nicely, he does not retract at the line of his diaphragm as if he has diaphragmatic disease, okay? Now, what does that mean? Well, both sides are equal. I know one side is not paralyzed. I've heard good breath sounds both sides equally here. And he has a little normal indentation here without the retraction of a calcified, scarred diaphragm, or a diaphragm that has a huge hernia in it, okay? So, quick and easy, and he's able to augment. Now, that's just his posterior chest, and I'm going to walk now around still with my diaphragm. Put your hands on your hips, please, sir. And now, just slow, easy breaths in, pause, let them out. Here, out, here, out. Okay, now relax. Take a breath. Out. Take a breath. Out. Now, my last maneuver, I do not want you to forget. It's done with the stethoscope. You're going to get your hands in here in a moment. I have determined that the cupula of his lung comes all the way up under the clavicle to the first rib, and that he does not have a significant sized Pancoast tumor on either side. Okay? You'll have no breath sounds in one supraclavicular fossa versus the other. And on a plain chest x-ray, when it's small to moderate, on a plain PA view, they may read the chest film as normal. You will miss Pancoast tumors if you do not listen here. Now, your hands are going to get in there, and we'll talk about that in just a second. But part of my inspection of the chest, I've listened to him. He's got good quality breath sounds. They come around. His expansion is normal, and I've listened up here. And I prefer, like examination of the thyroid, always from behind, as Dr. Siegel has already stressed to you. the proper way to feel the nodes in the neck is from behind also. And as Dr. Siegel has already emphasized, let me again plug the fact that you must move the sternocleido out or find it and go under it. And it's a little uncomfortable with the patient. Now take a nice breath in and out. Okay, if he had a nodal mass up in the top, he would raise it to my fingers, and likewise here. In and out. Turn your head slightly this way, forward just a bit. Now in and out. Okay, I feel nothing. Now, you all know Dr. Virchow's node is here. Let me talk to you about that. In most people, the anatomical drainage of the GI tract and the left upper lobe is to this node, Virchow's node. If this were rock hard and he lost 20 pounds and had bloody stools and had a clear chest x-ray, he's got a GI malignancy. If this one is if it's over here and there's a shadow up here, this upper lobe drains to here, it may be. I may find my bronchogenic carcinoma in Dr. Virchow's node. Over here, this node drains the left lower lobe and the entire right lung. So this is a large node, okay, for me to examine, okay? So frequently, small cell cancer, you'll have parenchymal lesions here and have disease here. So don't forget that, okay, because of its tendency to spread, to be found, when it's found, to be multifocal in where it is. Now, I'm back. Let me say this. As I listened to his exam, I have noted one place in particular that I go over if I usually hear something. If I begin to find cardiovascular abnormalities on the exam, I may go back and listen, if I haven't done intently, to a triangle right at the tip of his left scapula. Right at the tip, there's an area about the size of a baseball, and I've got my hand around it, just about that big, right at the tip of his left scapula, that has a tendency, when there is cardiac enlargement with pleural effusion, to compress one of the segments of the lower lobe and cause Ewart sign, A-R-T-S, Ewart sign. It is pathognomonic in a 12-year-old with a pulse of 150 who has occasional skip beats and came in with migratory polyarthritis. Ewart sign is classic for myopericarditis of rheumatic heart disease, okay? And all the old clinicians who worked long before we had so much penicillin and got rid of rheumatic disease almost, but when I travel to third world countries on mission trips and I see children who still have rheumatic disease and have had rheumatic disease and have rheumatic hearts, occasionally we'll see Ewart sign. It can persist for months. Literally, and you'd say that's impossible, but it does. As long as the heart, there's a carditis and the pulse is elevated, they have disease. That's not a problem in America now, but most of us learned a lot of our cardiology based on rheumatic heart disease. Now, as I get ready to examine the cardiovascular system, and I'm going to go back, I'm going to tell you some things about the physiology of the lungs in a moment. But while I'm examining, let me stay with the examination of the cardiovascular system. I've already checked here his periphery, the color, capillary rise, pulse volume. He's warm, he's perfused. I've already determined that for his upper extremities. Okay, and I'm going to auscultate now, and then I'm going to lie him down and continue. Always start with the bell instead of the diaphragm, and I usually start over on the right side because you get distracted. If you hear noise over here, you will not examine this side carefully, and I'm listening for really first heart sound and second